Good to go.
Hi guys, thanks for joining us today. My name is Tierney Leary. I'm a associate clinical therapist at WV Medicine, working in behavioral medicine department. I primarily work with people with substance use disorder. I run several COAT groups, and so this is a topic that is very near and dear to my heart. As an Appalachian woman, I was born and raised in rural Appalachia. I've lived here my entire life, and it's something that I have found not to necessarily be so much of a barrier, but something that a lot of providers, a lot of people in the community don't understand how treating substance use for people who live in Appalachia can be complex. It's a very complex but important thing to consider. So, what makes Appalachia unique? What makes treating substance use disorders here an important topic to discuss? So, from my understanding, um, I'm going to be talking about Appalachia as a whole, but really focusing on West Virginia because that's where I'm from. So when I'm speaking from my experience, I'm talking about West Virginia specifically. But Appalachia as a region is, very geographically complex. And that's led to a culture of people who have been raised in areas that can be more isolating. So there has been a more reliance on themselves. A lot of people in these communities still rely on farming to produce their own food. Canning, their old methods of preserving food. It's not an uncommon thing to find people who have cellars full of food that they grew and canned themselves. Um, and a lot of Appalachian dialect is something that is left over from the settlers that came here. And so a lot of times you'll hear words like poke, which means like a bag, or over yonder, which means like over there, or holler is really common. That kind of means like an old road, but also a valley. A lot of these things are deeply ingrained in the culture of Appalachia that a lot of people that hear them that are not from this area see it as a sign that they're uneducated, but it really is just left over from the settlers that came here and the culture that has become, part of West Virginia and Appalachia as a whole. But, on top of all of this, we do have the highest rates of opioid use in the country. And so when we talk about coming to a community with high rates of substance use and they are built on self-reliance and independence, but also very isolated. Resources are very hard to come by here. That can make the topic of how do we treat this in the best way possible really difficult. So some cultural context. So as I mentioned, people in Appalachia have, really big self-reliance. So asking for help, acknowledging that we have a problem, acknowledging that maybe I need to go outside of myself, outside of my family to seek help, is often seen as a weakness. And that's really, that kind of pulls on that self-reliance, the independence that is it's such an important part of the culture here. There is also a lot of historical trauma, economic hardship, and mistrust of systems. Um, so something that a lot of people don't really consider when you think about West Virginia as a state is how many large companies have came into this state and have, kind of wreaked havoc on West Virginia, have kind of poisoned the waters, the air. I think of, in the context of opioid use disorder, the Sackler family, the Purdue pharmaceutical company that kind of came in the 90s and started the opioid crisis. During the court proceedings, there were some emails that were released, and they, kind of talked about West Virginians. They called us, quote, pillbillies, and said, if people are going to misuse the drug that we produced and die, then, quote, good riddance. And so that is something that is known to the public here that, a pharmaceutical company came in, um, handed out medications to coal miners. And then, despite all of this, despite the company going bankrupt, despite like the lawsuits that were had, still, kind of talking about people in this region who are suffering as not victims, but quote, victimizers. There's a big part of, generational poverty that has happened in West Virginia because of these larger corporations that have came in, use the people to work, and then when the resources dry up, they leave, and they leave behind communities that were built around these jobs, but there's, no longer, money in the communities, money in the economy to support people. And so, you have communities with food deserts. And so people have had to go back to their roots in West Virginia and rely more on their farming and their canning again, because they would otherwise have to drive 2 to 3 hours to find a grocery store. But despite all of that, hardship, mistrust of systems, there's a huge focus on strong family and community ties in this area. So people also might be a little more hesitant to reach outside of their immediate circles, because, addiction is very stigmatized, even in, the state where we have the most people using. You would think that it would be a little more common, a little more acceptable to talk about, but it really isn't. There's also, a big part of our state has people that are very religious. I think, the most updated data that I found was around 75% of West Virginians identify as Christian or Catholic. And so that's a really big cultural part of this state, but also something that is stigmatized within those churches, that it's not, while it's safe to go to church, it's not necessarily safe to go to those people and talk about something as stigmatized as addiction and recovery. So I wanted to talk a bit about the landscape of substance use. So I had mentioned on my previous slide, but the Purdue Pharma company pushed OxyContin really hard in West Virginia around in the 90s. And it still remains one of the most prevalent substances used. Not necessarily oxy, but just opioids in general. And it was originally marketed as something that was safe and not addicting. And they targeted rural areas with high injury rates that came from coal mining, but also a lot of the manual labor that went on. And there were millions of pills sent to small towns, and this led to widespread dependence. I mentioned, during the lawsuits, the emails had came out, but even after they went bankrupt and it came out that they were held culpable, they really didn't want to take any accountability. They referred to us as victimizers, saying that, people in this community, we don't want to pay this money. They don't deserve this money. They just, are saying that they have an addiction. They're saying that they have a dependence, but it's not our fault. So this has really led to a very, very deep mistrust of pharmaceutical companies, but also government agencies in the state. I think about Monsanto a lot, down in the southern region of West Virginia, where they were burning, I think, Agent Orange, and they came out and had a lawsuit and, are responsible for cleaning up those communities, but they're one of many that has led to this very, very deep mistrust of what they call systems. And so when we think about West Virginia or Appalachia as a region, and we talk about, high rate of substance use, high rate of injury, high rate of prescribed painkillers, we also talk about like the intergenerational cycle of addiction. So this didn't start with people who are now in their 30s. It sometimes started with people who, in the 90s, whenever the opioid crisis started, it started with their parents or their grandparents, and is now kind of trickled down into younger generations, because it's, you're living in areas with food deserts, like I mentioned. You're living in areas where it's very hard to find work because of the geographical landscape of the state. A lot of times it's hard for people to have transportation, to find access to treatment, access to education, to find all of these answers that would be super helpful. And so as I move on to the next slide, talking about barriers to treatment, I mentioned how, when you're driving through West Virginia or any part of Appalachia, there's a lot of hills and the roads aren't necessarily maintained, but also something that people don't consider all the time is how expensive it is to have your own private transportation. A lot of people in this area do not have access to public transportation, and so they rely on having their own vehicles or, having rides from other people, but they have to have vehicles. Those vehicles are very expensive to maintain in West Virginia because of the weather and the hills and the roads. And, one of the barriers being poverty and unemployment makes it very difficult for you to have transportation to get to your doctor's appointments or to get to work whenever you can't afford to buy or purchase a vehicle. Stigma and confidentiality is a big concern in small towns. As someone who grew up in a county over, I run into this a lot in my practice of seeing people come in who I went to high school with, who I know. And so, being mindful that my presence there could make them not want to come back to that doctor's appointment because they know that I know them and they might assume that I know why they're there, even if I don't. Fear of being recognized and judged keeps a lot of people from coming in and seeking treatment. There's also a huge shortage of providers and treatment centers. Rural areas do not have enough therapists, doctors, programs, buildings, facilities to meet the needs of the state with one of the highest opioid uses. So as a therapist, what can I do? What can we do as providers, not just therapists, when we're considering all of this? So something that I have really learned in my practice is that even though I'm Appalachian and I understand the culture, I don't always understand the struggle. So building trust slowly, understanding that, they might not want to tell me their life story in the first 5 minutes. They might not want to tell me that in the first 5 months or in the first year. But that's something that I do consider as that, we're working towards a goal of them feeling safe enough to talk to me about this. I also try so hard to address the stigma, but do it compassionately. So helping people understand that substance use is not like a moral failure. It is a medical condition, something that they're here trying to get help with, and that's okay. It doesn't mean that they lost. In a lot of ways, it looks like they won when a lot of people in their communities haven't, because they're not here anymore. I also try to balance like the evidence-based part of being a therapist in this region, but also with my own cultural knowledge and sensitivity. One of my mentors, early on in my career, we were talking about, these people who were born and raised in rural Appalachia, that like hugging is such a big deal to them. And that it actually sometimes feels like you're rejecting them or that you don't care about them if they try to hug you and you say no. So it's finding a way to get both needs met, where I need to keep my physical and my ethical boundaries, but they need some kind of connection other than just sitting down and talking. In a way that I, try to incorporate that into my practices, we have a rule of not accepting gifts from clients, but like I will accept a holiday card because it's something that they thought about and they wrote something in there for me and it's very important to them. And for them in their culture, it's also my culture. I would feel, possibly hurt, possibly rejected if someone that I cared about who is helping me, who I'm telling them, hey, thank you so much for, this entire year that we've worked together. Like that's something that I'm willing to accept, knowing, how to balance both. And I also never stop advocating for their access to resources. So, being a case manager is one of the biggest parts of me doing my job as a therapist. When I have clients who need help with transportation, I'll talk to them about mode of care if they have Medicaid. I'll talk to them about bus schedules. We'll talk about all of the other, accesses to transportation that are available. We'll talk about how to get a cell phone through the department. We'll talk about, any resource that I know of that exists that could help them. I'm not, asking other people to meet that need for them. Like I will do my best to communicate that with them when I can, whenever it comes up in session. It's not all about identifying emotions, identifying feelings. It's how do I help this person with this problem that just came up? And if I have access to finding out the answer, I will do that, and help connect them with that. And so what are some cultural considerations we can have in therapy? So, I talked about 75% of West Virginians identify as religious. So that is something that does come up in session a lot. And, it's not all the time that someone comes in talking about my exact beliefs. But I do recognize that faith plays such a big part in people's lives in this region, but also in recovery. When we talk about a lot of people in AA meetings or even NA meetings, like they they really center that around their faith and their belief in a higher power. And so we will talk about that, and I will allow them to share their views and their feelings without, judgment, without doubt, without question, and just allowing that to be a safe place for them to bring this up. One of my favorite things about working with people in West Virginia, but also people with substance use disorder, is it is so fun to play on how resilient they are, how strong they are, how much they've overcome. One of my favorite things to do is to highlight how strong they are for coming into treatment, how strong they are for believing in themselves, for not giving up. And I'll highlight all of the bonds that they've formed in the community of COAT, the group that I work in. It's not just, the 12 clients that you have come to group. It's all of our COAT members, all of the people in the community, talking about how everyone does have a shared goal of staying alive, but also staying sober. And, I do really want to validate for people that they do have a deep mistrust in others. So one of the first conversations I have with a lot of clients is, they're coming in, they have, depression, anxiety, all of this stuff, and I want to talk to them about seeing a psychiatrist if medication is something that they're curious about. But one of the first things that comes up is that I don't want to see another provider. I don't want to see another doctor. I have so many doctors. So really trying to target, why they feel that way, but also encouraging them to give it a chance, to tell them that I've got your back. You are the expert in the room on yourself. If you try this and it doesn't work, I'm here to support you in finding someone that is a good fit, and kind of encouraging them gracefully to take that step whenever they're ready, and just allowing them to know that it's okay to try something and for it not to work. And just them knowing that they do have a support where they can voice an opinion if it's not overwhelmingly positive. We will work to find you a new provider, someone that you feel like you have a better connection with. I don't want it to be something that just goes unsaid and then just stops showing up. I want to acknowledge that in the beginning. And so obviously stigma is a huge barrier, but why does it hurt? In this area, we talked about all of the barriers to treatment, but stigma specifically with substance use. If people are afraid to seek help, then, if they're afraid to get better, when you're talking about opioid use disorder, that can be very deadly. And in small towns where there is one treatment center and there are 200 people that need to get care, some of those people might be afraid of being judged or being stigmatized by other people in the community. So something that we can do to help with this is to just, keep the confidentiality, understand how sensitive of a topic this can be, that, while we know as providers that we're going to keep their confidentiality, they're not necessarily, of the understanding that the other group members or the other people that they run into in clinic are. So just reminding them of, HIPAA laws of confidentiality, and understanding that, this might be something that is in the back of their mind. So this is something that I am checking in with people whenever they share not feeling comfortable in group, and I want to validate that as much as possible. And I also, it's very important to use non-judgmental person-first language. So shifting from addict to person with substance use disorder, person with depression, person with anxiety, but also normalizing relapse as a part of recovery. It's not a failure. You didn't fall off. It can fit in any of the stages of change. It's not something, we want to encourage them to celebrate, but we also want to encourage them to not be super upset with themselves, to be super judgmental towards themselves, to just try again, but also to not give up. And then, respecting their autonomy as grown adults who, are consenting to treatment, understanding that if they are not okay with something or are okay with something, and that is their decision, and that we cannot force them into treatment. We cannot force them, I cannot force them to tell me their whole life story. I cannot force them to come to therapy, but just respecting their choices. And I always want to address my own internalized stigma, because I think, despite being a provider in this field, in this area, there are always ways that this can come up in my brain of ways that I'm passing judgment or passing judgment onto their families. So always working with myself to, stay in supervision and question and not get too comfortable with the way that I'm practicing. I wanted to share a bit of a case presentation that someone that I've worked with on and off for about 2 years now. So I started working with this client of mine. He was a 40-year-old male, born and raised in rural Appalachia, dropped out of school in 7th grade due to lack of familial support. So he has very limited literacy, can't really read or write very well. History of some sexual abuse and family substance use disorder, opioids and alcohol, multiple incarcerations, lives alone, lower IQ, low socioeconomic status. Their current challenges: work long overnight shifts in the coal mines, of course, always exhausted from poor sleep, and having long commutes, moving from mine to mine. Some mines were 4 hours away, some mines were, 3 hours away. They rely on their coworkers for rides. They cannot afford their own vehicle, and even if they could, they're no longer allowed to have a license. And their workplace culture, based on how they identified it to me, it encourages drinking and meth use. They would talk about after work, the person that's driving, stops and gets a case of beer and we all pass it around and we all drink together, even the person that is operating the vehicle. And he also shared that when they were working these long, dark hours in the coal mines, they would also often use amphetamines to stay awake because they're exhausted, to have energy to do all of this really hard labor. And, they obviously had a lot of barriers to treatment, really embarrassed to seek help, really embarrassed to admit that they had an addiction. I hear this often, like, I don't think I actually have an addiction. I could put it down whenever I want to. So just having that initial conversation during the intake appointment is really challenging for a lot of people. Being the first person to tell them, like, you do meet criteria for a substance use disorder. That was a really big deal that took us a long time to work through, because they live alone and because this client has, very limited transportation. They are very isolated. So they rely on work to get their social needs met. And those social needs are being met by people who also use substances. A lot of the cultural factors that came into play, very proud of themselves for having a job, self-reliance and being a provider. He does have 2 children who he does not have custody of, but who, they are involved in his life. So being able to buy them gifts for their birthdays and Christmas was very important to him. Had a very, very deep mistrust of outsiders in formal systems. Extremely difficult to trust doctors specifically, especially men. They would identify feeling very mistrustful of men because they had been, they had suffered a lot of sexual and physical abuse by all of the men in their life growing up. And they also had a lot of shame around this trauma because it was of a sexual nature and incestuous. It was not something that they really had wanted to bring up, but was something that they eventually, after time and after trust, did feel comfortable bringing up in session, and then we were able to work on it. And so things that I tried to do, because this was a very unique circumstance for me, how I adapted therapy with this person is I tried to use storytelling and visuals in session. Look up pictures on my iPad to show them what I was talking about. Talked about faith and values based on whenever he brought them up to me. I would really encourage that kind of share insight. And I Googled as many coal mining metaphors for recovery as I could, just try to really understand what they do underground and try to conceptualize the framework and make it put it in his own language so that he could understand. And really wanted him to see recovery as a strength, not a weakness, not a sacrifice. He's not giving up things to be sober. He's actually, pouring back into himself. And we focused on a lot of small wins. So anytime he got more than 2 hours of sleep, we celebrated. Anytime they made it through a trigger without a relapse, we celebrated. And ultimately, we worked on adult skills. how to keep an agenda, how to keep a journal, how to write down appointments on their calendar because he had such a barrier around reading and writing. Just writing down an appointment or getting the notification on my chart, he didn't understand what that meant. So we found ways for him to remember to come to his appointments. And so still working with this person today. Things are going well and we are continuing the work together. He has shared with me that I'm the first therapist that he's ever had. And, he will say I'm his favorite therapist, but I'm the first one he's ever had. But, he has kept in therapy for over a year. And so when you look at where we started, someone who didn't want treatment to begin with, to be able to come and talk to someone about their trauma and their goals in life is actually a really big accomplishment. So, in conclusion, Appalachia faces a lot of challenges, but it makes treating substance use disorder very unique here. Culture, while it can be such a wonderful resource, can also be a barrier here. And that it's important for all of us, not just therapists, but any of us who work with people in recovery to adapt. There are just a couple of rules, but as long as you have your ethics and your boundaries, meeting them where they're at is the most important thing. And focusing on their hope and resilience is what I have found as a therapist to be the most life-changing part of treatment. And then I had something that Dr. Husted, I don't know if he's still on here, he said this to me when I was his student, and I use it all the time. They have to know that you care before they care what you know. And here are my sources.
Tierney,